Ladies and gentlemen, finally it seems as if we have passed the peak of the COVID-19 storm. In the meantime, as doctors from around the world have accelerated their efforts to understand this new disease and the processes involved in defining the severity of infections, the new research shows some newer ways in which this virus incapacitates the human body. More from Dr. Nayyar Raza Kazmi in this lecture. Hello friends, this is Dr. Kazmi once again, and today we are going to talk about the new challenges and some of the new concepts which have emerged recently in COVID-19. So to start with, I just want to share with you this letter which was sent by the NHS England to all the GP surgeries and hospitals and all NHS trusts in England over the weekend, and I will read it for you. It says, over the last 3 weeks, there has been apparent rise in the number of children of all ages presenting with a multi-system inflammatory state requiring intensive care across London and also in other regions of the UK. These cases have in common overlapping features of toxic shock syndrome and atypical Kawasaki disease with blood parameters consistent with severe COVID-19 in children. Abdominal pain and gastrointestinal symptoms have been a common feature, as has cardiac inflammation. This has been observed in children with confirmed PCR positive SARS-CoV-2 infection, as well as children who are PCR negative. Serological evidence of possible preceding SARS-CoV-2 infection has also been observed. There is a growing concern that a SARS-CoV-2 related inflammatory syndrome emerging in children in the UK, or that there may be another as yet unidentified infectious pathogen associated with these cases. PICS, which actually stands for Pediatric Intensive Care Society, wishes to highlight this alert to all pediatricians as well as colleagues in anesthesia and adult intensive care who may be involved in the management of sick children. Early discussion with regional pediatric infectious disease and critical care teams is recommended. So friends, this letter was sent to all the NHS trusts, and it's quite interesting that lately we have seen a few interesting cases of severe COVID-19 in the pediatric age group, and some of these cases have been presented with multi-system involvement, inflammatory involvement, like typical and atypical Kawasaki disease, and some had severe gastrointestinal symptoms. Now it's interesting to note that some of them were COVID-19 positive and some of them were not. But nevertheless, it was serious enough that the Pediatric Intensive Care Society of UK had to alert the NHS England, and then they had to send a letter to all the practices across England. Now, what has happened recently is that 19 cases have been reported in London, especially in northwest London, where they have seen severe cases which presented with multi-system involvement, Kawasaki-like features, and some of them were quite severe. One of them required ECMO. Some of them were admitted in intensive care. And luckily, none of them have died. The majority of them have made an uneventful recovery, and the others are in the recovery process. But it's interesting that a sort of a multi-system involvement has emerged in the pediatric age group. And when this report was shared, the other European health authorities, especially the Italian health minister, he also said that in Italy, the doctors have noted some clusters where kids had multi-system inflammatory conditions. The French health authorities and the US pediatricians have also reported some increase in Kawasaki-like features. And it's quite interesting that whether COVID is somehow related in causing this multi-system inflammation or not. Because the thing is that some of them were COVID positive and other was not. So the evidence is still emerging. We still don't know whether this is just an association or whether there is a cause-effect relationship between COVID-19 and multi-system inflammation. So this thing has stimulated a new debate and interest in pathophysiological processes in COVID-19. Because the adult practice has also reported that the increasing mortality in COVID-19 cases have been attributed not to respiratory causes. Rather, it has been attributed to cardiovascular causes like myocardial infarction like stroke, renal pathologies like acute renal failure. And they have noticed that the underlying theme in all these cases was endothelial damage. So the debate has focused on endothelial damage as a primary pathology in COVID-19. So in the next slide, I am going to show you the cross section of an artery. So here you can see that this is a cross section of an artery. This is the inner lining of the artery, and it is lined by specialized cells which are known as endothelial cells. So the endothelial cells are all covering this lining. Then we have the muscular part, the smooth muscle, which is responsible for some tone in these arteries, and then we have got the outer layers. So the thing is that this endothelial lining actually sort of protects the underlying endothelial tissue from coming in contact with the blood, because we know whenever there is an endothelial damage or when there is a breach in this endothelial lining, the blood, when it touches the tissue factors beneath, then it leads to activation of the coagulation cascade, and that leads to coagulation or clotting inside the lumen of an artery. Now, moving on, before we go and talk about how this endothelial damage is concerned with some of the things that we see in COVID-19, especially in severe cases of COVID-19, I need to give you a brief overview of basic biochemical processes that would help you in understanding how endothelial damage occurs and how COVID-19 actually accelerates all this process. So in this particular slide, you can see this is actually a simplified diagram of a mitochondria. And the mitochondria has got an outer layer, outer mitochondrial layer, then this got an inner mitochondrial layer, and inside then it has got the matrix. Now what happens, this is known as the powerhouse of the cell. So whenever we take the diet, the proteins, the carbohydrates and fats, ultimately they enter the mitochondria, and majority of them, they actually contribute 2 carbon atoms to this process, which then goes through this K stands for the Krebs citric acid cycle. So the Krebs citric acid cycle is basically a cycle in which different types of enzymes are involved, and ultimately the end products of the Krebs citric acid cycles are NADH and FADH2. So whenever we have got hydrogen attached to this NAD and FAD, these are known as the reduced states. So we at the end we have got a reduced form of NAD, which is the nicotinamide adenine dinucleotide. This is an H stands for the reduced form, and FAD, flavine adenine dinucleotide. So these two are the reduced forms, and they are important because these reduced forms can then donate electrons. So what happens once the Krebs citric acid cycle is completed, then these things, they go towards the electron transport chain, and electron transport chain occurs in the inner mitochondrial membrane. So we have got a few complex proteins which are lining the inner mitochondrial membrane. So what happens is, hydrogen, hydrogen has got 1 proton and 1 electron. So the NADH and FADH, when they are formed, they give electrons to these electron transport chains. So what happens is they release hydrogen. So hydrogen, as I told you, hydrogen is 1 hydrogen proton, which is denoted as H plus, and 1 single E minus, which stands for electron. So when this H is broken, the electron goes to the these protein complexes on the inner mitochondrial membrane, while the hydrogen ions are released into this intermembrane space. So as the cycle is going on, more and more electrons are released to these protein complexes, while the hydrogen ions are actually accumulated in this intermembrane space. Now, what happens to these electrons? These electrons jump from one protein complex to the other protein complex to the other one, till finally they cannot be reduced further, and then they mix with oxygen. Remember, O2. O2 is the most oxidized molecule in the human body. So the oxygen then accepts this electron, and then it combines with hydrogen to form water. So what is happening? NADH and FADH2 are contributing electrons. Electrons are jumping from complex to complex, and ultimately they go back, combine with oxygen and hydrogen to form water. Now what is happening? You see, in this process, there is a sort of an accumulation of hydrogen ions in this intermembrane space. So it's just like, a pressure sort of a thing is building up in this intermembrane space of the hydrogen ion. So finally, there is another sort of a protein on this inner mitochondrial membrane, which is known as ATP cyclase ATP synthase. So what happens is, all of a sudden it opens up. So just like you open the floodgates of a dam, and the rushing water actually drives the turbines and produces electricity. Similarly, when this is open, the ATP synthase, this whole flood of stream of hydrogen ion, it passes through that, and its kinetic energy is converted to form ATP. So adenosine diphosphate, which is the 2-phosphate form of adenosine, it actually combines with another form of phosphate. And in this process, the energy, this kinetic energy of the hydrogen ions, which is coming just like driving the turbine in a dam, what happens is this kinetic energy is used to store energy in the form of ATP. So ADP is converted to ADP, and this kinetic energy is stored in a chemical energy. So this ATP is then later utilized as the energy store by the body. So it's just the energy currency of the body. This is how energy is formed inside the cell. Now, why I wanted to show you this thing, let's suppose somehow there is a pathological process which simply blocks the jumping of the electron from one complex to the other. So what would happen? Finally, you would not be able to get, the electron would not be able to come back and form water. And similarly, the hydrogen ions, it would be released, and the floodgates would not be able to open. So you will have what we call as a lack of cellular energy. And this can happen in various disease processes, to which I would come later on. But this, in very simplified way, is how the energy is produced inside the mitochondria, inside the cell. Now, we need to understand the relation between COVID-19 and oxidative stress and damage, because this has been lately confirmed in various studies that the COVID-19 somehow leads to oxidative stress, and that in turn leads to damage to various organs, especially the endothelial linings of different organs of the body. So starting with that, now you need to have a look at this diagram. Now, this diagram is showing, this is the oxygen. We earlier talked about that oxygen can accept electrons, and it combines with the hydrogen then to form water. Now, if oxygen simply accepts an electron and does not combine with water, what you get is what we call as superoxide. So superoxide is a negatively charged oxygen molecule. So it's not inert, it's not neutral, it has got a negative charge, and it's quite dangerous because it's quite toxic. And superoxide is regularly formed in our body, especially in the neutrophils, and that's how the neutrophil kills the viruses and bacteria, because this is quite toxic. So this can kill viruses and bacteria. So O2, when it accepts an electron, as I told you, this happens in neutrophils, it becomes what we call as O2 minus, or superoxide free radical. This is quite toxic. And this process is actually helped by an enzyme which is known as NADPH oxidase. So the NADPH, which is a reduced form, actually becomes oxidized in this process, but it gives an electron to the oxygen, and oxygen becomes O2 minus, which is a superoxide. Now, this is a superoxide, it's quite toxic. Now, the body can further change it into another form by giving it another electron, and when it gives another electron to the superoxide, then it can combine with hydrogen to form hydrogen peroxide. If hydrogen peroxide accepts another electron, it becomes hydroxy radical, and this is another free radical, quite a toxic one, which has got the capability to damage the cells, has got the capability to damage cell membrane, can kill bacteria and viruses, and this is known as hydroxy radical. And if a hydroxy radical further accepts an electron, it is finally converted into water which is the inert form. So this process actually happens in various cells of the body, and it's going on. But at the same time, we have got certain enzymes which keeps them in check. So if excessive levels of superoxides or hydroxyl ions are formed, they are immediately broken down to inert compounds. And for superoxide, we have got an enzyme which is known as superoxide dismutase. It has got three forms, and interestingly, it requires certain minerals to properly function, which are number one, zinc, number two, copper, and especially in the mitochondria, the manganese. So superoxide dismutase is capable of breaking down this oxygen-free radical back into oxygen and as well into a hydrogen peroxide. Now remember, hydrogen peroxide is also a toxic compound, but it's not that bad as is superoxide or hydroxy radical. Nevertheless, it's more of a lesser evil. Now this hydrogen peroxide, when this is formed, this can be further converted to water. So, it would need 2 electrons further, which needs to be given to hydrogen peroxide to convert it into water. And for that, we have got an enzyme which is known as glutathione peroxidase, which we actually abbreviate by GSHPX. So this is peroxidase. So this glutathione peroxidase, basically what it does, it gives 2 electrons to hydrogen peroxide to convert it into water. Now the question is, where does this glutathione peroxidase get these 2 electrons from? And it gets its 2 electrons from the reduced form of glutathione, which is present in the reduced form. So here you can see these are 2 glutathione molecules in the reduced form. So they give 2 electrons, and in turn then it is converted into the oxidized form of glutathione. Now as this is happening, the glutathione in the reduced form is constantly being changed into the oxidized form, and because that is helping actually the hydrogen peroxide, which is being constantly formed, to convert back into inert water. Now it's very important that this oxidized form of glutathione needs to be converted back to the reduced form, and this is actually helped by the enzyme glutathione reductase. So what glutathione reductase does is that it would take the reduced form of NADPH, and I told you, we actually discussed that NADPH is formed in the mitochondria. It not only helps in the electron transport chain, but it also helps in this reducing the oxidative stress. What it does is the oxidized form of glutathione, which has been formed in this process, this is further converted back to the reduced form by glutathione reductase, which would convert NADPH into NADP+. So nicotine adenine dinucleotide phosphate, the positive charge is because the electrons are given back to the glutathione to convert it back into the reduced state. And it's also very important for those of you who have dealt with paracetamol poisoning. I think we know that paracetamol actually exerts its effect by reducing the level of glutathione reductase. Anyhow, that's a separate subject. Now, why we are discussing this thing? The thing is that, as I told you, that this whole process usually occurs in the body, but it's kept in check by these enzymes. So we have got the glutathione peroxidase, we have got glutathione reductase, and we have got superoxide dismutase. Now we know, coming back to the SARS-CoV-2, we know that SARS-CoV-2 actually infects the ACE2 receptors. Now this ACE2 receptors are not only present in the alveoli of the lungs, they are present in various endothelial linings as well. And research has shown that they are not only present on the inner lining of the alveoli, they are also present in the upper respiratory tract, they are also present in the gastrointestinal lining, and they are also present on the vascular endothelium. Now, when the SARS-CoV-2 virus, it blocks the ACE2 receptors, and you should understand that what ACE receptor does. ACE2 receptor basically is the receptor for angiotensin 2, and when the angiotensinogen 2 actually combines with the ACE receptor 2, it is converted into angiotensin 1,7. And this angiotensin 1,7 is then responsible for blocking NADPH oxidase. You can see over here, I told you that O2 is converted to superoxide radical by the help of this enzyme. So this enzyme is being kept in check by angiotensin 1,7. And where is this angiotensin 1,7 coming from? It is coming from angiotensin 2, which when combined with ACE2, it forms 1,7 and then helps to control NADPH oxidase. So NADPH oxidase, remember, NADPH oxidase is kept in check by angiotensin 1,7. Now, when the SARS-CoV-2 comes and knocks out the ACE2 receptors, what would happen? Angiotensin 2 cannot be converted to angiotensin 1,7. So you will have low levels of 1,7 angiotensin, and what would happen? That would lead to an unchecked activity of NADPH oxidase, and the oxygen molecule would be constantly converted to superoxide. And this superoxide, we call it as an oxidative stress. And what would happen is that then it has got the capability to damage cells. Not only damage cells, it can destroy the endothelial linings, it can destroy the epithelial linings, and it can then, and you know, when these endothelial lines or epithelial linings are destroyed, then it leads to a sort of an inflammatory cascade in which these damaged cells, they release certain chemicals, specifically interleukin 1 and 2, interleukin 6, and tumor necrosis factor alpha. And you know that these 3-4 types of factors are very much involved in what we call as severe inflammation. And if somehow this process goes unchecked, you will have a storm, a big storm, in which you have got these inflammatory cytokines, IL-1, IL-2, IL-6, and tumor necrosis factor alpha flooding your body, and then that can lead to multi-organ inflammation. And this multi-organ inflammation is what we're talking about, that currently this has been seen in certain pediatric cases, some of which were COVID-19 positive, some of which were not. So it's still quite early to say whether actually it is because of COVID-19 or is it just a simple coincidence, because as far as Kawasaki or Kawasaki-like conditions are concerned, atypical Kawasaki, we don't exactly know actually what causes Kawasaki disease. It's a sort of a vasculitis basically, and the exact etiology is unknown, whether it's caused by a virus or it's caused by any other sort of immune reaction. But nevertheless, we are seeing a sort of an association. Only time would tell if that really translates into an what we call as a cause-effect relationship. So to summarize all this, you just remember that NADPH, which is formed in the mitochondria, has got very important functions because it can helps in reducing the glutathione reductase, and at the same time the angiotensin 1,7, which is a byproduct of angiotensin 2 via ACE2 receptors. When that is destroyed by SARS-CoV-2, then we have got less angiotensin 1,7, and that leads to unchecked activity of NADPH oxidase that is constantly converting the oxygen molecules into superoxide radicals, and then they cause the oxidative stress. They damage the cells, epithelial, endothelial, organic cells, and that leads to an inflammatory storm, which leads to a lot of cytokines being released, and that further turns the whole thing into a positive vicious cycle, and more inflammation occurs, which ultimately gets out of control and can lead to multi-organ failure. Okay, moving onward. So this is an editorial which was recently published, and that was published by Dr. Luciano Gattinoni, and he is considered to be the father of ARDS in Italy, and I think he has been dealing with ARDS from the time I think I was in diapers. So he has written an editorial, COVID-19, different respiratory treatment for different phenotypes. And he actually took a number of cases, and he took their CT scan findings. And what he found was that in severe ARDS, where the PaO2 to FiO2 ratio was less than 100, that's classified as severe ARDS. And what he found was, if you look at these two groups of CT scans, and both were severe ARDS. Now here in this one, it's quite self-explanatory. You can see a lot of whitish shadows in the dependent parts of the lungs, and that is accumulation of interstitial fluid as well as fluid in the alveoli, what we call as severe ARDS. So the lungs are almost drowned in their own fluids, and that's quite understandable. We know that that how ARDS occurs, and especially in interstitial pneumonitis, when there's inflammation in the interstitial spaces and in the alveoli, the lungs are full of fluid, and then it leads to less oxygenation because there is not enough surface for gases exchange, and the oxygenation levels, they go down. So you can expect the arterial oxygen levels to be quite low as compared to the FiO2 level which is being given to the patient. But then there was another type as well, and here you can see the lungs are well aerated, so you can't see much of the fluid in the lung. Obviously, there are certain areas where you could see a bit of inflammation, interstitial inflammation, and some fluid in the interstitial spaces. But for most part of the lungs, they seem to be well aerated, and that's quite interesting because still the oxygen levels are quite low. So there seems to be a sort of a ventilation perfusion mismatch. And what they found out in these cases were that the blood flow to the lungs was reduced, and blood flow to the lungs can be reduced for different reasons. And like you can think of pulmonary hypertension, or if the blood is actually clotted, so not enough blood is flowing through these oxygenated part of the lungs, and that's why because if they can't get enough blood, then they can't get oxygen from the lungs, and the body would not get oxygen. So they found out that another type of ARDS, and these are again caused by COVID-19, these are the patients who had well aerated lungs, but their oxygen levels were quite low, and they found out they had large and small microthrombi in different vessels of the lung, not only the lungs, but then they found out it in different parts of the body as well. So something was inciting the coagulation cascade. So somehow thrombi were formed in different parts of the body. And in one of the studies, which was done by a Chinese doctor, they found out that a person who actually had COVID-19 and he was in the intensive care and he suffered a stroke. So they were doing the cerebral angiography, and in cerebral angiography, when you inject the dye, so the dye comes up as white, and the clot itself then shows up as a black space. And what he found out that when he reached the clot space, he could see in real time as he was trying to remove the clot, there were small microthrombi being formed in real time, just near to that particular clot. And he was amazed, and he said that in my 20 years of experience, I've never seen this phenomena where you could see the real-time thrombi being formed. So some form of active inflammation was going around at that time, that was causing that real-time thrombi to be formed while he was trying to remove the already present clots inside the cerebral vasculature. That was quite interesting. It means that there is some widespread endothelial damage which leads to clot formation. There is something which leads to this hypercoagulable state. Now, the question is how much, though we know this is quite confirmed in adult practice, we don't know how much this is common in the pediatric practice. Though these recent reports of some association with Kawasaki or vasculitis sort of phenomena is actually pointing that this might be the case in pediatric practice as well. Now, moving on, this is another paper which was published in Hospital Pediatric COVID-19 and Kawasaki disease novel virus COVID-19 infection. And this basically looked at the association of COVID-19 and Kawasaki disease. And this was done in America. And they found out this child, basically an infant, had COVID-19, and he developed Kawasaki disease. And here you can see the conjunctival inflammation. We know the Kawasaki disease has got a criteria, so you need to have fever for more than 5 days, and then there is a criteria in which you need there should be either there should be cervical lymphadenitis, oral cracking with strawberry tongue, we should have a polymorphous rash, and there are other features as well. So if all of them are present, we call it as typical Kawasaki. If some of them are present, we call it atypical Kawasaki. So here you can see a child who's got conjunctivitis with some limbic sparing. This was one of the findings, and then you can see this polymorphous rash, hives-like rash. You can see how much it is predominant on the lower limbs and to some extent on the upper limbs as well. And here you can see dactylitis. So there is some subtle swelling of the fingertips as well. In some cases, it can lead to some peeling of the skin at the digits as well. And recently, we have also seen that some kids have presented with just with swollen toes, which look like bruised, peeled toes. Rest of the parameters have been fine. And again, it's too early to say whether there's been any association with COVID-19 or not, but some of them have been COVID positive. So it's quite interesting to know that this virus is actually presenting in so much different forms. So this case actually was COVID-19, and it actually presented like Kawasaki disease. So we don't know at this point in time whether this Kawasaki phenomena was actually incited by the COVID-19, or is it just sort of a coincidence that they had viral infection with COVID-19 and also came up in COVID-19 at the same time? Because we know the Kawasaki disease is common in spring and autumn. We get more of these cases coming up when usually it's March and April, or sometime around the fall season, around October, November. But nevertheless, again, as I said, it's too early to say whether there is a real cause-effect relationship between the two. But nevertheless, it's quite interesting to note these things. Then this was another case report which was published in the Griffiths Archive for Clinical Graphs Archive for Clinical and Experimental Ophthalmology. This was published in the last week of April, and they describe a child who had confirmed COVID-19 with only symptoms of conjunctivitis and eyelid dermatitis. So it's quite interesting. This case was actually detected in China, and they found out that this child actually had conjunctivitis. He had red eyes and he had a bit of swollen eyelids with eyelid dermatitis. So he didn't have any fever or things. So they did the testing, and the testing came out to be positive for COVID-19. And probably this is shedding some light that there are ACE2 receptors on conjunctiva as well, and probably conjunctiva is another portal of entry into the human body, so the virus can infect the eye as well. And in this particular case, you can see the eyes of this child. So but soon here you can see this subtle eyelid swelling, some redness as well. And if you look at this parameters, he actually was afebrile, but then he had some elevation of the cardiac enzymes as well on his 11th day. So if you see, the myoglobin level was raised around 60, and the creatinine kinase isoenzyme ambifraction that was also a bit raised, borderline raised at 6.77. Lactate dehydrogenase was actually high early in the disease. Later they didn't repeat it. So you can see a little bit of increase in cardiac enzymes. And again, these cardiac enzymes seem that there might be some subtle myocarditis in COVID-19 infection. So it seems like the virus, even if it enters through the eye, something has got this capability of invading the bloodstream and then can cause inflammation in any part of the body. And especially if it leads to endothelial damage, that can lead to inflammation in that particular organ, that can manifest in the form of increased enzymes. So you can have increased liver enzymes, you can have increased kidney enzymes, you can have increase in the renal parameters, so on and so forth. Now this is another paper which was published 12 years back in Translation Physiology, and I went through that because it says that angiotensin converting enzyme 2 confers endothelial protection and attenuates atherosclerosis. And it's quite interesting because this paper actually shows that the ACE2 enzyme, because it is involved in conversion of angiotensin 2 into angiotensin 1/7, and that angiotensin 1/7 through through blocking the NADPH oxidase is helping in endothelial protection, because if your endothelium is healthy, your blood vessels are healthy, the chances of getting a clot in the blood vessel is reduced. But let's say if you have got lower activity of ACE2 enzyme for one reason or the other, whether it's COVID-19 or whether it's any other reason. In 2008 there was no COVID-19, but let's say there is any mechanism in which you knock out the ACE2 receptors, either it is in the lungs or it is in any other part of the body or like the endothelial linings. So what would happen is that the endothelium would be destroyed, the underlying tissue factors would be exposed, and then that not only leads to increased incidence of clot formation, it also accelerates the atherosclerosis process. So the arteries can get narrowed over a period of time, and when they get narrowed, there are more chances of complete blockage, which can lead to stroke, which can lead to myocardial infarction, which can lead to renal thrombosis, and obviously the consequences of all these things when they happen. So the ACE2 receptor, so again the limelight is now on the ACE2 receptor. That ACE2 receptor is not simply a receptor that is converting angiotensin 2 into 1/7. It is basically a sort of a receptor which has got so much to do in the human body. So it is protecting your endothelial linings, and your endothelial linings are in your blood vessels, and blood vessels are almost everywhere in each organ of the body. So if your ACE2 gets knocked out by COVID-2, all of the endothelial linings in the blood vessels inside your body in every organ are at risk of getting blocked by clots, by thrombi. And if that happens, what would happen in turn is that there would be a cascade of inflammatory cytokines which would be released in that area. That would lead to multi-organ inflammatory states, and that would lead to that vicious cycle which ultimately culminates in death. Now, this is another paper. Basically it was a letter to the editor, and this was published in the Journal of the European Academy of Dermatology and Venereology. And interestingly, they have described the acral cutaneous lesions in the time of COVID-19. So they have reported that the number of people with strange acral lesions, acral cutaneous lesions which are there on the finger or on the toes, they have increased. And they are describing it as pernio-like lesions. So you might be having some acrocyanosis, might be having some pernio-like lesions, and we normally know that pernio can be caused by lupus, and one of the treatments for lupus pernio is hydroxychloroquine and steroids. Quite interesting to see, and hydroxychloroquine has been used in COVID-19 as well. And in this particular slide here, you can see that there has been swelling of the toes, and there have been some lesions. So you can see these papillomacular lesions with some swelling. In some cases, there could be some peeling, to the extent that some of the US pediatricians have given it the name COVID toes. So they say if you see these types of toes, it's a good idea to test them for COVID-19. They might be having COVID-19. But again, it's very early to say whether it's just a correlation with the COVID-19 or it's actually causing that, because there is a sudden increase in presentation of these things. So obviously there seems to be some form of association, but whether that association translates into cause-effect relationship has yet to be seen. But now that's quite interesting, and the thing is that for pediatricians, if you come across these conditions, it would be a good idea to test them for COVID-19. Now from the adults, from pediatric side, I just want to jump over to the adult side, and this is quite interesting because as I told you that in pediatric, because the number of cases have not been so high, therefore there's a bit of dearth of research like randomized controlled trials or case report studies, things like that. The biggest study has come out of China, which I described in one of my previous lectures, that study which looked at the clinical parameters of 2,143 children in China. So most of the research comes from the from the adult population, and this is another paper, actually the pre-proof copy of a paper which is going to be published soon in Thrombosis Research. And in this, the authors have described severe COVID-19 infection associated with endothelial activation. And again, why I'm actually coming to the adult side, because earlier we talked about this biochemical pathways of endothelial damage. Endothelial damage caused by superoxides, oxygen radicals, and these oxygen radicals are formed because of ACE2 receptors being blocked. Now, endothelial damage leads to activation of the coagulation cascade, and that can lead to thrombi, that can lead to stroke, that can lead to MI, and various other consequences. So this was a 72 years old case which they have described, and he was a healthy male. So he had fever, and he had cough and shortness of breath. So he was admitted to one of the hospitals, and he was started on deltaparin, which is the low molecular heparin, and it was started on 5,000 units subcutaneously once per day. But because by 5-6 days his condition gradually deteriorated, and he eventually developed acute respiratory distress syndrome. He developed acute renal insufficiency. He had some altered loss of consciousness, like his mental status became changed. So he was intubated and shifted to intensive care unit. Now, in an intensive care unit, they did his D-dimer, and D-dimer actually shows you whether there is being any coagulation in the blood vessels or not. So D-dimers actually correlate with coagulation. So if you are having clots in your blood vessels, you will have high levels of D-dimers. Now they found out that the D-dimer level on the first day of his admission to ICU was 0.69. They repeated it on day 4 of his ICU admission, which was day 10 of his admission to the hospital. It was 2.55. Then on day 11th of ICU admission, it was 2.81. And on day 21, they found out that D-dimers was significantly elevated at 20.63. So you see, there's been considerable rise in the concentration of D-dimers. So there was something which was happening, progressive thickening of the blood, eventually leading to clotting. And they also found out that the von Willebrand factor on day 21 was 520, but there was an increase of 520% and an increase of 369% in his factor A. Now, here in this diagram, you can see this is the endothelial lining, and when you have got the blood on the inside of the loop. Now, beneath these endothelial linings, we have got this factor, we have got this von Willebrand factor. And this von Willebrand factor, when it combines with the factor 8, it actually it actually provokes the coagulation cascade, and it causes coagulation. Coagulation, in other words, is clotting. So it would lead to clotting in the blood vessels. So you can see here a high level of D-dimer with an increase in von Willebrand factor by 520%. So what does that mean? It simply means that this von Willebrand factor, which has increased by 520%, is coming from the subendothelial parts. And how did the subendothelial parts were exposed? It's simply because of the endothelial injury. So in these so many days, the viral activation and knocking out of the ACE2 receptor had led to increase in superoxide radicals, which then damaged the endothelium, and the von Willebrand factor was released into the blood, which then combined with factor 8 to cause coagulation, and then thrombi were formed. So he was started on unfractionated heparin on the 21st day of his admission in intensive care, and then it was repeated on day 24 and day 29. So you see, gradually now the D-dimers have come down from 6.26, and then it came down to 1.94. So unfractionated heparin, and it's quite interesting because he was started on the prophylactic dose of deltaparin, but still the D-dimers increased, and that simply means that there has been endothelial damage because the blood here, because he already had deltaparin, but somehow because the endothelial damage, the von Willebrand factor was able to come into the blood and then provoke this thrombotic cascade. At the same time, they found out that his anticardiolipin antibodies and beta-2 glycoprotein antibodies were positive, and they were not of the IgG type, they were of the IgM. So somehow it leads to an altered immune response as well, that leads to production of the antibodies, IgM, acute phase antibodies, the cardiolipin and beta-2 glycoprotein, which can further aggravate this situation and would lead to formation of microthrombi. Especially this is more prominent in the small vessels and medium vessel, where it can lead to microthrombi and can destroy the cellular function, because once you have blocked the blood vessel, the blood supply, so what would happen, you would not the cells would not be getting oxygen, and the cell would not be getting oxygen, then the Krebs citric acid cycle that we were talking about, which happens in the mitochondria, that would be poison. It would not be able to form, and further what would happen, these these radicals would form inside the cell, and this would lead to a vicious cycle, which will ultimately lead to massive damage to the human organs. So to summarize it, what we have found so far is that the evidence is still evolving. So, and it is showing that SARS-CoV-2 virus is not only a respiratory virus, but it can enter through various portals, and hence it can be considered as a multi-system virus. So it can enter through your eyes, it can enter through your GIT, and then it can cause sort of that infection in all the organs. The predominant pathological process that we have found so far is epithelial and endothelial damage, leading to activation of immune and coagulation pathways. So again, I would reiterate the same thing, that the ACE2 receptor, when they are knocked out, the angiotensin 1-7 goes down, which actually angiotensin 1-7 actually keeps a check on NADP oxidase, and when that check is removed, then a lot of free radicals are formed, and these free radicals are responsible for damaging the epithelial and the endothelial lining. We also have found that this cytokine storm leads to widespread tissue damage, and it's a consequence of the endothelium. So whenever you will get the endothelial damage, it would lead to inflammation to surrounding tissues, that would lead to massive surge in the interleukin-1/6 tumor necrosis factor alpha, and that's going to further aggravate the tissue damage. And because of the multimodal pathological process, uniform management guidelines may be a bit difficult to adopt, because different organs are affected, and we said, the pathological process also multimodal. It's ACE2 receptor damage, it is oxygen free radical formation, it's endothelial damage. So having a uniform guideline may be a bit difficult to adopt. Recently, we have come across some trials where remdesivir is giving some promising results. But again, it's too early to say. I think with the passage of time, as the dust settles down, the pandemic is brought under control, and there are some randomized controlled trials, we might be able to see some guidelines. But for the time being, uniform guidelines to be adopted at the moment seems to be a distant dream at the moment. So this was all about some of the latest pathophysiological research and interesting things that we have seen in COVID-19. If you've got any questions, you can ask me in the comment section below. Please do subscribe to my channel, and stay safe and stay healthy. Thank you very much.